There. Okay, so welcome everyone, and we are going to go into fairly rapid fire. Let's see what we got. Okay, so what we want to accomplish with these is we want to go through, have gone through all the basics with the fellows, and then we can do fairly rapid fire lightning rounds to reinforce all those concepts and make sure that you're ready for any example of the slides you've seen instead of the one example that you did at conference. So, okay. Let's make sure everybody is in focus. So, first off, what we got to do is we got to make sure the monitor is in focus.
So can you move that camera setting window over? Because the recording will be done.
Absolutely. And we gotta make sure.
I think you can actually do that.
I want to make sure that we want to take that off. Get that on. Okay, now we should be good. Okay. Are everybody's eyeballs in? Make sure we are colored. We are. Okay. Shane, you want to start us out?
So, in the what looks like a dermis, it may just be a different cut. It looks like sort of a vellus. There, maybe.
Okay, so you have villi.
Mm-hmm.
And what does it look like your structure's in?
That looks like epidermis.
Yeah, kind of. What's epidermis doing way down there?
Or this cyst-like.
Yeah, cyst-like thing, or maybe related to an expanded follicle. So an expanded follicle-like structure. And then you got villi, and then what else do you have besides the villi?
I would imagine like some corons and grains.
Like lots of little corons and grains. So what would that suggest? A warty dyskeratoma. Why does this one not connect to the surface? Just plain a section.
Okay.
Right, which is real life. And so one of the things you're responsible for is real life practice, which is, every picture you see, every textbook picture is beautiful, it's centered, you see everything. Real life is a cut to the left, a cut to the right, right? And so that kind of thing is within your scope of practice. So it's anything within your scope of practice is within the testable scope of practice, right? Okay, well done. Let's see. Nicole, are you passing or playing?
I'll pass and let them play.
Okay. Gee,
I guess we're realistic.
you get to do that in this room.
Looks like we have a little baby seb there.
Like a little baby seb.
Thin, but it's got a little horn pseudocyst, it looks like. Some of it looks rather lentiginous form.
Yeah, so lentiginous-form, which is a good word. So part of it looks like a solar lentigo, and then you have focal horn cysts, so that would make it a,
Baby seb.
like reticulated seb.
Yeah, but you can say that's alternative.
And then portions here where in the epidermis the cells are quite large.
Those we might call large cell acanthomas.
Yeah, and large cell acanthomas are a mixed bag, anything from minimal deviation Bowens and AK to sebs and lentigo. And this is a nice example of a solar lentigo, partly reticulated seb K, partly large cell acanthoma. Very good.
This looks like another seborrheic keratosis.
Like a seborrheic keratosis, and why is that epithelium different from this epithelium?
It looks like it might be more of a clonal seborrheic
Yeah, like a
keratosis.
clonal seb. So the cells of a seborrheic keratosis are small keratinocytes. They probably derive from or differentiate towards the cuff that surrounds the acrosyringium. So they're about the size of acrosyringeal cells, and when they're clonal, they look a whole lot like Hydroacanthoma simplex, intraepidermal clonal poroma, because that's from the cells of the acrosyringium. This is from the keratinocytes right next door that surround the acrosyringium. So the two are closely related, very similar appearing. And the keratinocytes tend to be smaller than normal epidermal keratinocytes, very uniform. Unlike normal keratinocytes that change and become more squamous towards the surface, these are very uniform throughout, so they don't undergo normal maturation. When a clonal seb becomes inflamed, only the clone is inflamed. When it becomes irritated, only the clone has spindling and squamous eddies. When it's pigmented, only the clone is pigmented. So usually have that background of uninvolved cells for comparison. Nicely done. Rob.
Clear cell acanthoma.
Clear cell acanthoma. Why would that be a clear cell acanthoma?
So a couple reasons. One, the sharp transition zone, which is the first thing I noticed, but also the overlying para.
So abrupt transition from a normal epidermis to a pale glycogenated epidermis. You noted a parakeratotic crust. What other kind of cells are always in there mixed with the parakeratosis?
Neutrophils.
Neutrophils and fragmented neutrophils you would expect to be scattered throughout that epidermis as well in a clear cell acanthoma. So if one were thinking of a differential diagnosis, you might put psoriasis in a differential where you have acanthosis, you have neutrophils, right? And the key would be to note that abrupt cutoff in the glycogen. Just thinking of things that one might have to consider in a differential diagnosis. Okay. How about this one?
Real small papule keratinocytes all look regular. Looks like get the sub architecture.
So it is certainly an acanthoma. I don't see horn cysts. Why is this epidermis different from that epidermis? Which is normal, which is abnormal?
It's more pale.
So the pale, where the arrow is now, is probably the abnormal. If this were a clonal seb, all of those pale areas would be surrounded by normal. In this case, the two are more side by side, right? Instead of the one surrounding nests of the other. So, two possibilities in differential. If you had atypia to the keratinocytes,
Would you think about like a clear cell Bowen?
yeah, like a clear cell clonal Bowen's disease. In this case, I don't really see any atypia to the keratinocytes.
And then you think about just clear cell acanthoma.
Exactly. And another name for clear cell acanthoma is pale cell acanthoma, because often they're not so much clear as just paler, right? They're not quite as glycogenated as a clear cell acanthoma. So if you're struggling and you're saying, well, this could be Bowen's, this could be clear cell acanthoma, start looking for your neutrophil fragments. If it's a clear cell acanthoma, you should have your neutrophil fragments there as a clue that it's a completely benign lesion. If they're absent, then look again, because maybe it's Bowen's. Okay. Blake.
Looks cystic in nature.
Looks cystic in nature, and in a chapter composed of cysts and acanthomas, you had about a 50-50. Go ahead.
There's like a thick eosinophilic debris inside the cystic wall.
Yeah, so the debris is not amorphous debris, but probably keratin, and the nature of the keratin is helpful. So in a pilar cyst, the keratin is uniform, dense, and red. In an epidermoid cyst, it's lamellar, like shredded wheat. In this case, it's neither. It's compact, but it looks like someone's taken a tiny little cookie cutter and punched out tiny little white holes all through it.
Pilomatricoma.
So pilomatricoma can have pale cells like that. This doesn't look like matrix epithelium, though. I see papillomatosis, hypergranulosis in the dells, and a corneum that's compact red with tiny little cookie cutter, apparently that's hard to say, holes cut out of it. So, Nicole, if this weren't down in a cyst, but were on the surface, what kind of thing?
Verrucous.
Sounds like a wart, right? So is there any kind of a wart cyst?
There is.
There
Verrucous
is.
cyst.
A verrucous cyst. So a verrucous cyst, or cystic papilloma, those are both names for it, is basically you get HPV in one of two structures, either a hair follicle or an eccrine duct. And it turns into a cystic wart. Any portion of it looks like a wart. The ones on the eccrine, from eccrine duct, usually are cystic Myrmecia on the palm or sole, so they have the red inclusions of a Myrmecia type wart, whereas the verrucous cysts in hair follicles usually are common wart virus. So any portion of the wall looks like a wart, papillomatosis, hypergranulosis in the dell, that unique stratum corneum of a wart, which is a compact red corneum with little round cookie cutter holes in it, all forming a cyst. Well done, sir. Okay, David.
So, undulating epidermis is like somewhat compact orthokeratosis. It's like a reticular seb, some horn cysts.
So reticulated seborrheic keratosis. It is somewhat like a lentigo with slender bulbous fingers, pigmented bases, kind of like slender Mickey Mouse fingers dipped in chocolate. And then it has little horn cysts. The keratin is fairly compact, but breaks up into a lamellar shredded wheat pattern, so it is good for a seb keratin. This patient is from Australia, and so is shown in true anatomic position, head downward, right, with the corneum down. Justin was probably overly nice to you and turned all the specimens so they were corneum side up. In terms of preparing to take any future exam or to sign out in real life, you need to be ready to sign out in however the slide comes to you. The last thing you want to do is, on a timed test, start flipping the side around because you can only interpret things right side up. So, do you have a sibling? Okay, who has a sibling? Okay. Brother or sister?
Sister.
Would you recognize her upside down?
Yes.
Then you should be able to recognize any histopath upside down, right? So you just get used to recognizing your sister upside down. Good answer, by the way. Okay. Okay. So, Caleb, what do you see?
Cyst-like structure.
A cyst-like structure, very good.
Kind of thin surrounding epithelial type with some shark tooth-like appearance.
So, shark tooth-like red cuticle, name 2 cysts that can have that.
Steatocystoma.
And?
Dermoid?
Dermoid. Those are the 2 that can. So you want to pull back. Which of those 2 has vellus hairs in it?
Steatocystoma.
Which has terminal hair?
Dermoid cyst.
Yeah, that's usually the easiest. Brian, you got something right on that tip of your head. It is now gone. Yeah.
I don't think that was
What? I saw it from scan. That's right. That is how I view the whole world. So, that was good. You actually get points for that. That was very good. So this one has no sebaceous glands in the wall whatsoever. Is it still a steatocystoma?
I think so.
Yes,
Because
it is.
Yeah.
It is completely recognizable sans the sebaceous glands. And so that's the whole point, that you need to be able to recognize common variants of things or uncommon variants of common things. And one actually very common variant is you don't happen in your field to see sebaceous in the wall, and yet you have the characteristic shark tooth-like cuticle, wavy wall, just like the sebaceous duct. So this is a hair follicle. That's part of the sebaceous duct. This is an exaggeration of the sebaceous duct opening into a cyst. So the other name for a steatocystoma is simple sebaceous duct cyst, which kind of describes what it is. And you don't have to see the vellus hairs and you don't have to see the sebaceous glands in order to make the diagnosis. Okay. Justin, that's all you get. That's your specimen. What is it?
Looks like an epidermoid cyst.
Yeah, or contents of an
Yeah.
epidermoid cyst, and you can tell that because you have a mass of lamellar shredded wheat keratin, roughly composed into a circular mass. That would be the contents of an epidermoid cyst. Very good. How would you dot it?
Dot EIC.
Or dot contents. Actually works. It tells you contents of, it says laminate keratin compatible with the contents of an epidermoid cyst. Okay.
So we have an epidermis structure. It looks like there are villi in there again.
Okay. Looks like villi, and what are the little round bodies? Okay, so if you were a Frenchman and you were trying to describe round bodies, you would call them corps rond, right? And in fact, when they were described originally by Derrier, he thought they were an infectious organism. He thought it was fungal. He thought he was seeing spores of some sort. He was wrong. But fortunately, he was very clever, and he waffled and said they were round bodies, corond, right? And then the grains are the flat, dark things that resemble grains, right? And they are not core grains. They're just grains. So corons, grains. And then you see the altered keratin. So what's your differential for this? It's not deep in a follicle. It's not really a big crater. So, Nicole, you want to help him out?
If my brain was working like an epidermolytic egg, I can never think of the name.
EHK?
Yes.
But this
No.
is more
But the
acantholytic.
No, it's the acanthoma one.
So like an acantholytic acanthoma
Or
could do it, or it could be, it's a little big for Grover's, so it could be a small Warty D, a big Grover's, someone with Derrier's, any of the things that have acantholytic dyskeratosis. Okay. So, Christina, what do you see here?
Oh, I know it's a vellus hair cyst because you have a different shot of it where it had vellus hairs.
Yeah, and this one without vellus hairs?
Just very loose orthokeratin in there.
And in terms of the way it's vertically oriented,
You can imagine it was like connected to a hair follicle.
yeah, so this is a follicular cyst, so a benign cyst of follicular origin. And then in the other cut, it's filled with vellus hairs. So what's the pathophysiology of eruptive vellus hair cysts? It's a defect in...
The loss of the ability, like they're extreme. I don't know, like they just don't come out to the surface anymore, but I don't know, the loss of like a molecular level.
So it's a defect in keratinization where the keratin isn't shedding properly, and so you end up with a retention cyst that retains the vellus hairs as well because they're caught in the keratin and they're not shedding either. So it's sort of like trichostasis spinulosa run amok and turn cystic.
Is it a keratin like 16 or 17 defect?
You may be correct, sir. I do not know the answer to that. Let's confirm it, and we can report back to the group. The way you said it, it sounds like you're fairly confident that that's true.
I feel like I read that somewhere.
Okay.
And then it kind of exemplifies the similarities to Pachyonychia
Congenita, where you get similar cystic structures. Really good.
I'll Google it.
Dr. James LeGroux.
I mean, it just looks like sad, like flaky.
Like, it certainly has flaky keratins. Some might say lamellar, shredded wheat. If you are a pastry fan, this would be good pastry, right?
Mm-hmm.
Nice and flaky, like a
Butter
croissant.
there.
Butter. Lard actually makes good flaky pastry as well. So, and if you look at the cells are somewhat large, right? Sebs usually have small keratinocytes, smaller than the surrounding normal keratinocytes. These are larger than the surrounding keratinocytes, but there is a kind of weird variant of Seb that merges with large cell acanthoma, where it usually has some features of lentigo, some features of Seb, and the cells are large. So remember, your Seb cell is usually around the size of an acrosyringeal keratinocyte, small, but then you have that large cell variant, which merges with large cell acanthoma, reticulated Seb, and lentigo. see a cyst.
Yeah, on first glance, it looked like a proliferating Pilar cyst. It's really holes.
When you look at your cyst wall,
Yeah, it just looks like it has a granular layer and there's a lot of cretinous debris.
so I see this is actually collagen. So it's kind of disrupted a little. That's collagen. It looks pretty much like an empty cyst.
So like a ruptured cyst.
And the cells get large and round. I don't see them flattening out, and I don't see a granular layer. But what I do see is in the surrounding tissue, lots and lots of lymphoid aggregates. Where might this cyst have been located?
The lateral neck.
Like the lateral neck, in the area of what fetal structure?
Like a brachial cleft.
Like the branchial cleft. So the branchial cleft and bronchogenic cyst may be variants of the same thing. They're certainly closely related. Bronchogenic cyst has clearly identifiable respiratory epithelium, cartilage, things that are differentiating towards bronchi. Branchial cleft cyst is more primitive and has lymphoid aggregates.
Suppose it's just like a pigmented hyperkeratotic seb.
Like a pigmented hyperkeratotic seb, and the cells are larger or smaller than the normal keratinocyte?
Smaller.
In this case, I'd say larger, even though it's not the second choice. So correct, larger, with this being normal. So that's normal.
That's normal. Okay. Yeah, larger.
And larger. So this one, not surprisingly, is pigmented and has some lentigo-like features, and is that kind of merge of large cell acanthoma, pigmented seb, lentigo. So I see all that tissue, and then I see this.
So this one looks like got a couple things. So this looks like it's got a granular layer.
Has a granular layer, and is the granular layer normal or exaggerated?
It's exaggerated.
Exaggerated with coarse granularity.
Mm-hmm. And it looks like you got, I don't see a lot of inflammation, but it looks like just a lot of keratin debris.
So keratin debris, and does it have retained nuclei?
Yeah, it's kind of got a throat.
And are the retained nuclei flat or round?
They are round.
What else do you know of that has coarse hypergranulosis and round porokeratosis?
We freeze our hair all the time. You have one line.
Uh-oh. So, a wart.
A wart. And in fact, when you look at the corneum, it is not lamellar, it is not uniform. In fact, in areas, it has little round cookie cutter holes punched out of it, just like a wart horn. And in other areas, it hasn't quite gotten there. You see degeneration where it's headed towards little round cookie cutter holes, but not quite there. Has the coarse hypergranulosis, round parakeratosis of a wart. So this would be
Another one, just a HPV.
another verrucous cyst or cystic papilloma, depending what term you like to use. Okay. How about this one? So, Blake, what do you see?
Sebaceous glands surrounding a cyst.
Yep.
I don't necessarily see them. Well, maybe connecting to the cyst.
Not with any associated hair follicle. And how about the cyst lining?
Looks just like epidermis.
Anything unique about the epidermis?
baby shark tooth.
Little baby shark teeth, little baby jaws there. So this is Steatocystoma. So you just recognize Steatocystoma with sebaceous glands, without sebaceous glands. If your sister wore a scarf, would you recognize her?
Most likely, yes.
Would you recognize her without the scarf?
Depends where the scarf is. Like,
So like she's holding up a bank with the scarf in front of. So you have to recognize Steatocystoma with the sebaceous glands, without the sebaceous glands, just like your sister with and without a scarf.
you can get just dermoid cysts with sebaceous glands. How do you differentiate that?
So dermoid cyst, you expect it's defined by the presence of other adnexal structures beyond the sebaceous glands. So you'd have terminal hairs, eccrine glands, apicrine glands, some other adnexal structure in the wall.
Okay.
So we got skin, and then we've got that.
So very thin. So it's a cyst with a very thin lined epithelium.
Yeah, cyst with a simple epithelium.
Um,
So it's not a stratified squamous epithelium. And then is it empty or is it filled with guck?
filled with guck.
So a
Maybe.
guck-filled cyst with a simple epithelium is most likely located where?
Is it a it's like a ciliated cyst? Maybe?
So ciliated cyst on the leg of a woman or
median raphe.
median raphe in a guy.
Yeah.
Correct. And those are closely related cysts. So ciliated cyst in a woman often strays a little away from the median raphe to the leg. And men tends to be right in the median raphe. And they are simple epithelial cysts filled with crud.
Looks awfully seb-like.
Looks awfully Seb-like. So we have, what makes it awfully Seb-like?
Well, it has some-
Could you elaborate, sir?
Sure, the three are kind of reticulated, and I see some, I guess, the horn cyst or a horn cyst in the epidermis there.
So it's an acanthoma
Right.
with lamellar keratin cysts and pseudocysts. So we have if you can ask Mark to help us. We've got an allergen in my briefcase that they need downstairs for patch testing. If he can just grab the syringe in my briefcase and take it down. Mark, I think he just came into his office. He should be right there. Okay. So is this A, irritated, B, inflamed?
Inflamed.
What's the difference?
Inflamed, you see like a lymphoid.
Inflamed means
endodermis,
lymphocytes.
and
Irritated means
like those little
squamous eddies and spindling. And the classic experiment with that is you take croton oil and you paint it on a seb. The seb becomes red, but when you biopsy it, there's not a lymphocyte anywhere around. Instead, there is spindling and squamous eddies. So it is irritated, not inflamed. So this is, in fact, a seborrheic keratosis. And then we're going to look. And at this end of the seborrheic keratosis, you start to have tripolar mitoses, and in fact many mitotic figures, and irregular contour of the nuclear envelope, and solid hyperchromasia, and it is now crushing a normal basal cell layer. So now you have bones that arose within a seb. It happens. So sebs can give rise to Bowen's disease. They can give rise to melanomas. They can give rise to all sorts of things in collision. And so if you see a seb with one funny part, don't look at the 80% that's obviously seb and say, this lesion's okay. Remember that the 20% may be what you need to biopsy, which can be a secondary neoplasm arising in a seb. So that's the little lesson on that one. Okay. Justin, what kind of an acanthoma is this?
This is Verrucous.
A verruca. A little endophytic kind of verruca with big red inclusion bodies. So what kind of endophytic verruca is this?
Myrmecia wart.
Myrmecia wart. So it has the coarse hypergranulosis, red inclusion bodies, a stratum corneum that is compact, has round porokeratosis in it. In areas it looks like someone has punched out little round cookie cutter-like holes. So that is the features of a Myrmecia wart. If you get a verrucous cyst on a palm or sole, it tends to have a lining that resembles this type of wart, deep palmoplantar warts, because it just happened to get into an eccrine duct. Okay, so Shane, is this a cyst or an acanthoma?
Acanthoma.
It's an acanthoma. Well done. Describe this acanthoma.
Well, there's porokeratosis in areas, and then on the other side there's orthokeratosis. The cells in there are smaller than the surrounding cells.
So kind of seb-like. And then, what are all of these brown, long, snaky things?
Those are dendrites.
Melanocytic dendrites, and they're melanocytic dendrites all through this thing. And in fact, when I look at it, I don't see much melanin in keratinocytes at all. There's a little bit. Melanin and keratinocytes are arranged as a cap on one side of the nucleus, like a little umbrella or cap to keep the sun off the nucleus, right? And I see one or two of those, but through most of the lesion, the melanin has not transferred or left the melanocytes. It's retained all within melanocytic dendrites. Do you have a name for such a lesion? A melanoacanthoma. Absolutely correct. So a melanoacanthoma of skin is a type of seborrheic keratosis where the pigment is contained largely within the dendrites of highly dendritic melanocytes. A melanoacanthoma of the oral mucosa is a benign reactive lesion that's not neoplastic at all, but has some histologic similarity. Whoops. Okay.
Yeah, clinically, how does that look different than a pigmented seb?
They're often weirder. You look at it and it's a stuck-on thing, but it's really dark, and you're worried about melanoma, and it's not really as keratotic as a seb, and you can't make out horn cysts. In fact, they hardly ever have horn cysts. It has a little bit of a crust on top. So when you look at it, you're thinking pigmented lesion versus weird seb. And the answer then is weird seb on biopsy, right? Okay, so Nicole, why don't you help us with this one?
So automatically, there's too much atypia. All the cells look too jumbled.
Too much atypia, too jumbled.
I can already see mitoses that are way too high in the epidermis, so I'm thinking Bowens.
So you're thinking Bowens. But is it full thickness atypia, or is the atypia kind of just scattered?
It's kind of just scattered.
And the clinician says, Bowens? And this person just had lots of bumps in the genitalia.
Oh, then it's Bowenoid papulosis.
Bowenoid papulosis, correct. And Bowenoid papulosis is a transition between a wart and Bowens disease, kind of midway along. And Bowenoid papulosis was named at the AFIP at a time when the standard treatment for a male with Bowens was simple excision, and the standard treatment for a female with Bowens was radical vulvectomy. And the AFIP was receiving radical vulvectomy specimens for these things that were basically warts with scattered atypia in them. And in an effort to put some stop to that practice, they coined the term Bowenoid papulosis. And initially their concept was that it was a funny-looking wart that was Bowenoid but was benign, so stop doing radical vulvectomies. Fast forward to when I was in medical school, we were taught that if you found HPV changes on a cervix, that was a look-alike for Bowens, but it was totally benign, and it helped you rule out Bowens and malignant change. Fast forward another 10 years where there was the aha moment that all of these cervical cancers were HPV-induced. So, back when, in the Dark Ages, the thought was that HPV mimicked malignancy, whereas now we know it is the cause of the genital malignancies. So what the AFIP did was not a bad thing, it was a good thing because it did stop the routine practice of radical vulvectomy for tiny little multicentric lesions of Bowens. Okay. Christina, how about this?
Pilar cyst.
Pilar cyst. What makes it a pilar cyst?
It's epidermal lining on of the cyst. There's no granular layer, and then the inside.
No granular layer, and it does not become flattened squamous.
And then the debris of the inside of the cyst just is,
Uniform
thick
red keratin.
red keratin.
Yep. Very good. So pilar cyst. How are we doing time-wise? We're still okay.
This just looks like an epidermoid cyst.
Like an epidermoid cyst. Do epidermoid cysts usually have that kind of outline?
No.
And focally, I see a little bit of a shark tooth cuticle, but it's filled rather than the oil of a steatocystoma, it's filled with lamellar keratin. So how do you get a shark tooth cuticle like a steatocystoma?
Dermoid.
You have said it about 5 times now, and I keep ignoring you. So dermoid cyst. And so now you would look around, and in fact, you do see both eccrine glands embedded in the cyst wall and terminal hair follicles embedded in the cyst wall. So portions resemble a steatocystoma, but it has lamellar keratin rather than just oil and vellus hairs. It has terminal hairs, it has eccrine glands, so it is a dermoid cyst. And what is the most common location for a dermoid cyst?
The lateral brow.
so lateral brow is correct. So. We're going to skip that. Well, actually, we can do it because you are an upper here, so you can do anything, right?
Yes. So this looks more like a seborrheic keratosis.
Looks like a seborrheic keratosis, right?
What is
That's
that?
right there.
Oh, and that looks like a little cornoid lamella.
Like a cornoid lamella, and in fact there are multiple cornoid lamellas. So this thing is kind of psoriasiform, or like a psoriasiform seb, but it has multiple cornoid lamellae,
So,
and it was located on someone's rump.
So, well, at first I was thinking Ilbin, but like a Dowling-Dagos or...
So
I
any
thought
type of
porokeratosis.
porokeratosis that has a psoriasiform plaque, like an acanthoma on someone's backside, with multiple cornoid lamellae. Anyone want to jump in? So porokeratosis pitotropica, P-Y-T, pitotropica, is on someone's backside. Pitotropica is a unique form of porokeratosis that tends to be, rather than a circle with a cleared center, rather than being an annular lesion, it is a plaque type lesion that you're thinking is this psoriasis versus is this Bowen's or extramammary Paget's, because it's this stable, kind of weird looking psoriasiform plaque on someone's backside, and you biopsy and you see psoriasiform acanthosis, kind of like an inflamed acanthoma, but with multiple cornoid lamellae.
What's different from the peyote? The
Porokeratotic eccrine and osteoduct nevus, completely different.
Okay.
That's music box spine keratoderma and Thompson soles. But both are, variants of porokeratosis that you need to recognize. Let's make sure we're getting all the important things here covered.
Say like maybe a irritated seb at first.
Like an irritated seb, you see squamous eddies and you see spindling. And is it uniform throughout the lesion, or is it little circular clones?
Little clones. throughout.
And is the normal epithelium pigmented?
No.
But are the clones pigmented?
Yes.
And then you see lymphocytes. So you are correct, sir. This is a pigmented, irritated, inflamed, clonal seborrheic keratosis. Okay.
I think that's
All of the above.
Okay. So, Brian, what's this?
Relatively similar look from the last one.
Relatively similar, except that, is this an exophytic lesion or is this an endophytic lesion?
Yeah, this is more endophytic.
So an endophytic lesion with all of these little whorls.
I think about inverted follicular keratosis.
An inverted follicular keratosis, which is basically an irritated seb in a hair follicle, right? Usually a massively dilated hair follicle. So, irritated seb in a dilated hair follicle is inverted follicular keratosis. Okay. Blake.
I see porokeratosis. Is it clear cell?
It is clear cell or pale cell. It has an abrupt transition. So what would you look for to distinguish this from clear cell bones?
Is there any atypia?
You'd look for atypia, and you'd look for scattered neutrophils. And neutrophil fragments carry erectic debris. Correct. Whereas this one,
There you go. Looks like clear cell acanthoma.
yeah,
I don't see a
exactly
lot
the
of-
same thing. Correct.
Yeah, I thought you were reinforcing a point or something. Sorry.
The point is, look at the slide, don't listen to me. There may be lots of red herrings, things that take you in the wrong direction. The answer's on the slide.
Can the granular layer help a little too? To distinguish, like we get lost in the granular layer.
It can. Some Bowens loses, some Bowens that's HPV-induced has an accentuated granular. But you tend to have, usually in a clear cell acanthoma, usually not much of a granular, but a scale crust on top of it. Okay. So.
Has similar like reticulated architecture, and there's a lot of pigment here, and I can't tell if it's like in dendrites or
Looks like it's within dendrites.
like Melanoacanthoma.
And I see spindling of keratinocytes.
Second irritated.
So an irritated melanoacanthoma. And is it uniform, or is it little clones embedded in normal epidermis with larger keratinocytes?
I'll take the latter.
You'll take the second one. So this, you are telling me, is an irritated clonal melanoacanthoma. Yes, you're correct, sir. So what we're doing right now in terms of lightning rounds is what you need to do on your own. There are 100 slides per box. You need to do about 500 before you own the chapter. So you just have to run through them, and no one can do it for you. You have to do it on your own. Okay, so how about Shane, this one?
Looks like you have sort of an exploded granular layer.
Like an exploded granular layer, all shot full of holes,
Right. So,
forming an acanthoma that is kind of crateriform.
right.
So a crateriform acanthoma with an expanded granular layer shot full of holes and a compact horn.
That's dermolytic.
An epidermolytic acanthoma, and 90% of these are located where? 90% are genitalia.
Okay.
So 90% are genitalia. There have been numerous studies to see if they're HPV-induced. They are not, according to all the studies to date. But the patient and the physician often think the differential is between a venereal wart and a squamous cell carcinoma, usually the latter of the genitalia. So it's usually a big relief when you are able to tell the patient it is merely an epidermolytic acanthoma of the genitalia. And you start to explain what that is, and they say, you're telling me this is not cancer and it's not contagious, right? Okay, I'm good. Okay, so unfortunately we have a little bit of bubbling there. We're not going to be able to do this one. That has to be recover slipped, so we're going to set that one aside. It was actually a thyroglossal duct, which would have been a good thing to review, but we're going to have to recover slip that. Okay, we're going to do this one. And this one, in the interest of time, will be our last slide. So, Christina.
Looks pretty Seb-like.
Kind of Seb-like. So when I go, it's, tell me about the corneum.
So it's orthokeratosis.
Tell me about the corneum.
Keratosis.
Tell me about the corneum.
Keratosis. Orthokeratosis. Orthokeratosis.
And focus of parakeratosis.
Oh.
So what is this? So, Ilvin, correct. Very good. And we are done. So for all of those who joined us online, thank you, and we will see you next time.